So quick introduction for everyone on the line. Mike Ryan is the EMS chief with Duncanville Fire Department in Duncanville, Texas. Very experienced in the PECC role and has a lot to share with y'all. So Mike, I'll let you take it away.
Thank you. Yeah, I'm the EMS chief for a fire department. And how I knew I was the PECC is because I'm everything for EMS in the fire department. So a lot of people out there, I think, are wondering who is the PECC of their agency. And if you're attending this meeting, like we've said before, it's you. We just don't know it because it's not a formal certification. And anything in the fire service, how I got an EMS was, if you showed an interest in it, it was you. And I wrote our protocols from early on in the department and was the only one interested really in it. And over time, we've gotten more and more involved and advanced, progressive, however you want to call it. So a few years back, we decided we were going to be a part of the EMSC and the PECC and have a better role at the semi-insistence of my medical director, who is a pediatrician. I work for the Biotel system in Dallas out of Parkland Hospital, which we have multiple medical directors, and the one that is assigned to us is a pediatrician. And so she encouraged us to go to the EIIC website and download the checklist and the toolkit. And so basically now anything we carry for adults, we carry for children. Our protocols are designed, it's adult and pediatric, and then we actually make a separate pediatric protocol. It's in a pink binder. It's easy to see, because I think we all understand that very few of our calls are really children. And in Duncanville, only 7.2% of our calls involve children. 0 to 9 is 2.6, the 10 to 18 is the remainder. Less than 1% of those are critical kids. And so we don't get those innovations. We don't get that. We don't draw up the drugs on a regular basis. I teach PALS and PEP as well. And I realized when JACO started making nurses from children's hospitals and cooks here in the Fort Worth area in Dallas, they started requiring them to have PALS. Well, PALS is insulting to pediatricians and people that work with kids. The test is ridiculous. But one good thing about it was I had been teaching things like SVT, that's very rare in children, but it's from my experience, because we really didn't see them that much. And through teaching them, they're like, oh, it's a little more common than you think it is. And then I taught more nurses from cooks and children's. They're like, oh yeah, we see it all the time. Then I started teaching that part of PALS. Well, we don't see it in EMS, but they see it at the children's hospitals. And then the more I heard about it, the more I realized, maybe we're not doing real good assessments on kids. So I bought pediatric electrodes, changed up our PCR system to where if they fit into a certain protocol, they had to have an EKG. Within 2 months, one of my guys told me, hey, Chief, we had an 8-year-old SVT yesterday. And then a few months later, then we had another 10-year-old SVT. I'm like, oh man, we've been missing this. We get zero feedback from our EMS liaison at Children's Hospital. So if we're totally off on what we think that is wrong with that kid, nobody ever lets us know that. So I've had to be a little bit more aggressive in getting feedback on calls, and I encourage our guys to do that. So every item we carry for adults, we carry for children. Some of those I was able to combine, like our traction splints, whether we're going to traction splint a kid or not is, we'll use our vacuum splints or whatever's best for them. But if we had to, we carry the Schleichmann. I think that's how you pronounce it. I don't even know. But there's so many out there. So it's a combination for adults and children. One of the things about being a PECC, and like I say, you're probably it, whether you realize it or not. Anybody that shows interest or has any kind of input, it's not just one PECC. We have more than one guy here in Duncanville in case something happens to me that understands the purpose. I saw in the chat that everybody was wondering about policies. Do we have policies on a PECC? And we really don't, because I don't want to have that in our policy to where the EMS chief is it. Because our next EMS chief, we're a civil service fire department, Texas Civil Service. It could be somebody really just trying to promote. And we don't want to keep it at that. But as long as you have somebody that shows interest in it, that is involved in the protocols and making sure that you have pediatric protocols and you order pediatric equipment, they're the PECC. It could be the brand new guy on the fire department, for that matter. It could be the oldest guy. I am the oldest, one of the oldest guys, but I've always showed an interest in the EMS side of the fire department, especially kids. I have 12 grandchildren, so I guess that just comes with my world. But one of the things we realized through me teaching PALS and whatnot is a study came out a few years ago. I actually came out in January of 2017, and it showed that 37% of all drugs given to kids were the wrong dosage. And we couldn't figure out why. That's why if you've ever watched a PALS DVD, if you had to suffer through that part of it, you realize that there's scenes in there where a doctor goes, okay, nurse, let's give 3 milligrams of epi. And the nurse goes, excuse me, doctor, wouldn't that be 0.3 milligrams? And the doctor goes, yes, thank you so much. And everybody's like, that doesn't happen. Well, they didn't know if at that point, if the doctors were ordering the wrong dosage or we're drawing it up under a stressful situation. And they realized through the study associated with it, it was the Braslo tape. The Braslo tape shows a dosage. So like Versed or whatever it may be, and I think it's lorazepam for the yellow range is 1.3 milligrams. Well, lorazepam comes in 2 different concentrations. And so they realized this was a problem. We suck at math. We all suck at math. We think we're good at CPR. We're really not. We suck at CPR. So we have monitors now that tell us we do good CPR. We suck at bagging people. So we have BBMs now that have manometers and PEEP and all that on it that tell us we're using, doing good volume. I think AED pads are going to be thicker coming up here that go through hairy chested people. So we had to have a system for kids that makes things easier. Well, they realized the Braslo did not have our dosages in volume per se. So there was no milliliters. It was just milligrams or micrograms. So make sure wherever you're at, your Braslo tape, the 2017, so they own the rights to this red arrow. Right down here, it'll say 2017 edition. The difference between this one and the other ones is now every dosage in here breaks it all the way down into milliliters, not just milligrams or micrograms. So it's the concentration, the dosage, and the volume. So all the math is done for us, and that's what makes life easier. Another thing we do here, just to make sure that we don't make these mistakes, and all of these mistakes, everything we have has a name attached to it. Your department's the same way. If somebody messes up, that rule has their name. I'm just lucky that not too many have my name attached to them. But we've made mistakes over the years, and to ensure we don't, there's cheats out there. So everything has a little cheat code to it. So we buy these. They're called the Epi Convenience Kit from Certidose. It has syringes in them for epi, for anaphylaxis. And it comes with color-coded syringes, 2 of them, and an epi 1-to-1. So I don't know if you can see this very well, but they're for anaphylaxis. They're color-coded. So the epi comes with it. And if it ever expires, just get rid of the epi. The syringes stay good for a long time. It's just the epi that expires. On the CPR side of it, we have the PALS syringe holder kits. And I don't know why it comes with atropine and lidocaine. We don't use that one too much, but it comes with a measuring tape that has the color codes on it. I know my screen's trying to blur that out. And then we have these. They just snap onto our epi 1-to-1. 1-to-10. And all the dosages are numbered on there, 1, 2, and 3. So it keeps us from making them. So we have to go back and figure out the dosages later on. So these are all from Certidose. They're kind of expensive, but they last for a while. So there's a cheat to everything because we're not comfortable with kids. None of us are. My nurses that I teach from children's, they don't like working on adults. Kids are their comfort zone. The ones that work at all the other hospitals don't like working on kids. The adults are their comfort zone. None of us in EMS have a comfort zone with kids, really, unless you work at a pediatric facility on the side or something. So we make sure that we have our protocols, they're readily available. We make sure our measurement tapes, we carry a Pediatric tape and the Braslo. The reason we carry Pediatric tape, it's the one with the black arrow. They all own the rights to the color of the arrow, I guess. but I've seen yellow ones and green ones. The nice thing about Pediatape is all the drugs are in alphabetical order from, I think it's adenosine all the way down to sodium bicarb, but you can get a two-sided one as well. All the skills aspect, the equipment is all up here in alphabetical order from the first cardioversion all the way down to suction catheters. We also use the Hantevi method. Now, I know how this goes. I had to sneak my Hantevi method in with PALS that we renew every 2 years, because if I went to my guys and said, hey, we got another system in place, man, they'd lynch me out back. So I had to kind of sneak it in there, so they were a little bit more open to it. Now, once I went through the Hantevi and they realized they could figure out these drug dosages by age, well, our dispatch tells us the kid's age, the adult's age, when they punch us out to the call for a CPR progress. So before, if we had a 5-year-old and we used the tape-based method, we had to get there, find our Braslo tape, measure the kid out, figure how much, what weight range he was in, what color range he was in, figure out the dosage, and it's going to be like 1.7, 2.1, those kind of things. But with the Hantevi method, it's by age. It's 13579 on your hand. Everybody calls Dr. Hantevi at conferences because it's a combination of the word hand and his name Hantevi. And so we know going into this that a 5-year-old, 135, weighs about 20 kilograms. The benefit of this is we know 0.01 milligrams per kilogram of epi. That 5-year-old weighs 20 kilograms, which is 0.2 milligrams. We take it all the way to milliliters and we keep it kind of locked in our heads. So we know that 2-year-old's getting 2 milliliters of epi. A 1-year-old gets 1, a 3-year-old gets 1.5, a 5-year-old gets 2, a 9-year-old gets 3 milliliters. And we know we're going to get 3 full dosages out of that epi 1 to 10 when we run on them. So we simplify this. We make sure we carry all the supplies that these kids will need. We have childbirth simulators here at the fire department. We have pediatric intubation heads. We have infant intubation heads. We have difficult airway intubation heads. We have the IOs. We have 2 or 3 of those. We use grant money for those from our RAC system, our regional advisory councils. We make sure that we have those because we don't run on them enough. So when you don't have experience, we all know what takes the place of that, and it's education. So we have to make sure our guys stay up on this. Our CEs, we make sure that we have special population CEs, that we understand how these kids work. We don't get real big into the ventilators because we're in a Dallas area. We don't make the big long transports, and we don't have to have the critical care type of stuff. But we make sure that we have the things in place to make sure our guys feel comfortable with it. So we make sure we have all the mannequins and whatnot. We also have to stress to our guys, we would take our kids that were critical to the closest hospital, and we realized that was not working. The closest hospital really doesn't have good pediatric care. So it was actually worth it for us to take the extra time to transport them to the pediatric facility, even on some CPRs and whatnot. So those are questions you need to have with your medical directors and whatnot. Make sure you download that checklist and make sure you do the toolkit. It lists everything out. It's on the EIIC website, and it tells you the equipment you should be carrying for kids. We've incorporated this whole thing from a medical side all the way into social work. We hired a social worker through our medical direction. So our social worker worked for 13 different agencies. We're to the point now where some of them are getting so busy with social work that they're hiring their own. We've incorporated that with the children, especially during COVID, when so many kids, we were seeing a huge spike in child abuse and family violence as a whole. Our shootings and stabbings went up, I think 1,000% during that first year of COVID, but we also saw a lot of child abuse, and we really had to kind of have special sit downs with our guys that they are the ones that have to contact Child Protective Services. That's not one of those things where they send me an email and then I'd follow up with it. They have to do that themselves. Same thing with our adults, especially in Texas. I don't know what the rules are everywhere. So we've incorporated the social work into children as well. Now, we don't see a lot of kids compared to our adults, but it's there if we need it. And that's the whole point of this. It's there if you need it. Now we're doing it with our cops. We do a regional concept here. There's 4 cities that work as one big fire department. And now our cops have gotten into that care program and they're seeing more kids than we do, but it's at least we incorporated it in. They hired their own social worker and organizer. They got a $2 million grant through the Dallas County system, and they see a lot more of that than we do. So just make sure that what you do for adults, we're able to do for kids. That's the PECC. You're probably are the PECC. It's anybody that took enough interest to be in this. You're it, man. And it's all it takes is just somebody saying, let's make sure we have everything we need to take care of children, and we're comfortable with it, semi-comfortable with it. And that's really about it.
And in the interest of time, we will move on to Robin Goodman. Robin is a part of the AIC. She helps a lot with our knowledge management domain, but she's also a very active member of the Pediatric Liaison Nurses in Los Angeles County. And she's going to talk a little bit about being the Pdln. So go ahead, Robin, take it away.
All right, thank you. So good afternoon, everybody. I am super excited to be here. I could talk about being a Pdln, or what we call the Pediatric Liaison Nurses here in Los Angeles County, essentially our PECCs. I've been a part of this group for almost a little over 18 years now. And so just a little background on our group and kind of how we got started. So back in the 80s, as it was discussed earlier, Dr. Seidel and Debbie Henderson had some ideas on how we could make our system better, or this pre-hospital as well as the hospital system, and make them connect and actually improve care for children. So we're located in Los Angeles County in Southern California. We currently have approximately 74 emergency departments within our county. 42 of those are approved for pediatrics. And what that means is those are the only hospitals that can accept patients via the 911 system. So those hospitals agree to participate in a system where they apply to be in the system. And then they have to be surveyed every 3 years through the process. And the survey process and the application process and the standards are set up to adhere to the 7 main domains of pediatric readiness. Our group initially just started as a Pdln. Every hospital is required to have them if they're in the EDAP system, as well as an EDAP medical director. Our Pdln group meets monthly and has for many, many years. But over the last few years, we really recognized that we wanted to have more of a role in the system aspect and not just in our hospitals. And so we went to the EMS agency and we really advocated for kind of a seat at the table in developing pre-hospital protocols, really to make the system better for everyone. And so we could have that continuity of care throughout for our pediatric patients. And so now we have the Pediatric Advisory Committee, which meets quarterly. After every session, our group offers free CME, BRN, and MICN credit through educational sessions, as well as we host annual symposiums with specific pediatric emergency care content at a really low cost for anyone that wants to attend. So that's kind of a little bit about our history. It's a really hardworking group. I will say most of us were put into this role kind of voluntold. I was a very young, newer nurse in the emergency department, and the person that had the role prior to me was going out on maternity leave. I was not going to be returning. And so they just said, hey, would you want to do this? I truly had no idea how it would impact my career and really kind of help me create the passion I was looking for in emergency nursing. And so over the years, I've really followed through that and just continued to advocate for improved care for children within our region, but also our state, and then now nationally. All right, so the hugest part, and I think the scariest part about being a Pdln is truly the quality aspects of it. And so I've had amazing mentors, one in particular, Laura Garcia, who has helped me. They don't teach a lot of QI essentially in nursing schools. So really getting the help I needed to better understand the QI role and taking that on. I think the important thing to remember as a PECC is that you're not going to fix everything at one time. It's really overwhelming at the beginning, and understanding if you change one thing, you make one difference, you make one person more comfortable in taking care of a pediatric patient, you've done a good job. It's just those small little steps that you can keep doing over and over again to improve care overall within your hospital and then more of the system. For me, it's important to reach out to those community hospitals that maybe aren't EDAPs and how I can help with them. To Mike's point, I think PECCs need to have that communication. And so I was always someone that wanted to follow up with our smaller hospitals. And if they transferred a patient to us, I would make sure I would follow up with them and go over if there's any resources or anything. When I was reviewing their charts as it came over and looking at the care we provided, I would always provide them with resources protocols, guidelines, anything like that. Anything that is created, we should be able to share. Why are we all reinventing the wheel and making more work for ourselves? So let's get together, network, and make these jobs easier. So you can see in the right-hand corner, that is our EDAP standards of quality that we are required to do and submit to the EMS agency. So you can see number 3 at the bottom, that is we can identify 2 quality indicators in addition to items number 1. We can submit 2 additional PUI indicators or things that we're looking at. For my facility, we were having an issue with patients having RRTs or rapid response activations and code blues being called on the floor within 12 hours. And so we kind of identified that 12-hour mark as being a significant kind of mark for us. And so we started looking at these patients. It was upsetting to the floors. These patients were having to go to the ICU. So we were really trying to figure out how can we make this better, because ultimately this was impacting patient care. And so we created a quality improvement initiative that really started looking at this concept of how can we improve this for our pediatric patients. Things that helped us when we're creating that, it's really kind of finding your success and how you're going to do that. Number 1, you have to start with a clear plan. And that could be your longest step, but I think it's also the most important step in everything that you're doing. You need to make sure your definitions are clear as to what you're looking for. Your indicators are very clear. Those are, I think, the most important part. And then when you create a tool to audit charts, another person that was completely uninvolved or more than one person needs to look at all your information before you send it out or before you start working on it. Because in your mind, it's really easy in going through it, but you have to have someone else kind of run through it to make sure you've made it very clear as to what your expectations are. You've got to make it relevant to the staff at the end of the day. Why are we doing this? People don't want extra work. So you've got to make it relevant and you have to follow up with them. There has to be good oversight and you have to be enthusiastic. You've got to be the cheerleader for this, even though it's tough. You got to put a smile on your face and really just try and again, make it relevant, follow up with people in a positive way to kind of get buy-in from your stakeholders. And so when we talk about our stakeholders, it's really begin at the beginning. When you're creating that plan and developing those tools and looking at the problem, you've got to have the stakeholders engaged from the very beginning. If you create all of this content and don't do it until the end, get those people involved, you're setting yourself up for failure. And so when I say engaging nurses, that means all nurses, even travel nurses, float pool nurses, any nurse or anyone that's going to be involved in the care of this patient needs to be engaged in this process or at least have a look at it before you implement it. All of our physicians and advanced practice providers should be engaged or at least representation from them. Our support crew. For us, for that scenario, these were patients that were leaving the emergency department. So how could we teach our transporters and our techs and our UAs to make sure that, hey, did we get a set of vital signs on these patients? What are we doing before this patient leaves the floor? And then running it through not only your committee structure, but your orientation structure. Make these changes part of your culture that when you onboard people, you're educating them to pediatric emergency care needs and specialized kind of initiatives that we're doing to make sure we're maximizing those outcomes for pediatric patients. So what are barriers? For this specific initiative, it was resistance hands down from almost every single person. No one had the time, the pace. We see, we saw an average of over 90,000 patients a year. So of course, people just wanted patients to move, the equipment, and then really people just felt it was not necessary. So it was truly, our job to make sure we were making people understand this is necessary. This is impacting pediatric outcomes. These patients are going to the floor, they're having an adverse event, and then they're being sent to ICU or they're having to require additional treatment because we didn't stabilize them or we didn't manage them properly within the emergency department. So it really was a kind of a timeout stop moment for us to recognize we need to slow down and we need to make sure we're back to looking at these patients prior to them leaving our area. So steps taken, we recruited champions. And I will say one of our biggest successes with this was recruiting some of our most frequent flyers. So some of the ones that when we were going back and looking at these RRTs and code blue activations, we had some common themes. And so we really worked with them and said, we want you to take this on. And they become some of our biggest advocates for this initiative, truly. But also we needed to initiate kind of role modeling. So we needed to target, our more senior staff members, our more senior physicians, those that, the squeaky wheel voices. And then we all had to role model the behavior, even when people weren't looking. You know, we weren't letting people slide by without getting vital signs. Like we were stopping, even if they were rolling out the door, we were stopping, making sure the vital signs were normal or within normal for age limits. If not, you know, that we had to document that, stop and talk to an attending, get a little huddle going, create a plan, which all had to be documented. And that was all clearly aligned and written down in our plan. As we move through the process. Got to have lots of oversight. Initially, we audited every chart of every single patient that went to the floor, which was a tremendous amount of work. Initially, once we started stabilizing a little bit, we started doing spot checks, and then we specifically looked at those patients that had RRTs or code blue activations moving forward, and then follow-up. Lots of follow-up with individuals, but we tried to make it positive. Punitive follow-up when you're trying to get a QI initiative going really is detrimental to the project. So really trying to build people up, celebrate their successes, what we're doing well was what was most important to us. And so that's where we really celebrated those small steps. Maybe we got partial vital signs initially, then we moved to complete. Maybe we documented a notification, but then we documented notification and plans. So anytime we saw improvement, we celebrated that. And we really tried to focus on the positive aspects of this initiative. We knew we were successful when we saw less rapid response in code blue activations. We actually went, I believe, 17 months without having any, which was tremendous for us. Looking at our data beforehand. So we saw an increased compliance with vital signs across the board. And then we also saw, which we weren't really truly expecting, improved communication. One thing our nurses started to feel was more comfortable communicating with our providers on what they were seeing in the patient or what they were concerned about. Where before, I mean, we had great relationships working with our healthcare team, but sometimes people were a little bit more nervous or uncomfortable to go up and explain something because they wanted to get the patient out. And so we did see improved communications between our, our collaborative team, which was great. We shared this throughout our organization. We actually submitted some work on this through the ENA Emergency Nurses Association. And then we provided updates in our staff meetings and huddles, as well as our quality wall of fame, and then gave a lot of direct feedback. Again, a lot of positive direct feedback, which was really helpful to people as well. Sustainability, we did expand this to include most of our discharge patients as well. And so looking at their vital signs prior to discharge as well. And then we continued this by the monthly reviews, looking at, was it a care system? Was it a care problem, a systems problem, an equipment problem, or communications? And then continued to build on those successes throughout the process. And I just want to say, again, reminding everyone to make change, it takes little steps. This is our next symposium that actually starts next week. If you guys want to QR code that, again, it's small sessions of conferences that we offer CE for, and you can find the information on our website. And that is it for me.
Wonderful. Thank you, Robin. I'd like to introduce, Dr. Sujit Iyer. He is a pediatric emergency medicine physician at Dell Children's Medical School in Austin, Texas. He has also been very experienced in developing PECs within the region. He partook in our Pediatric Readiness Quality Collaborative, which was a few years ago now at this point. But we invited him here to talk to us today about kind of what he has done in his region. So with that, go ahead and take it away.
Thanks, Meredith. Can you guys hear me and see me? Okay.
Yes.
Perfect. Okay. So just a little background. As Meredith said, I'm a pediatric ER doctor. And actually, you can go to the next slide. I think for most of us on this talk, it's really great. We get to hear from a wide variety of people from a wide variety of areas. And I was just going to summarize a little bit of our story here and see how some of it could relate to where you may be too. I've had the luxury of always working in these big, beautiful children's hospitals where I could push a button and get help from about 100 people. I'm in Austin right now. I used to train at Texas Children's, and I was in Philadelphia also. But the unique opportunity here in Austin was that our children's hospital, which is there at the top, is also part of an adult hospital network of 10 neighboring hospitals. And at the beginning of some of the natural outreach that our children's hospitals were doing, our CNO actually came up with the idea and said, should we be doing more to actually help out our community hospitals? And being part of the ER, we absolutely agreed. And when we really looked at the numbers, we realized that we probably should have been doing this for a long time. So as you can imagine, we got small hospitals, big hospitals, medium-sized hospitals. Some hospitals in more rural areas saw as few as 300 kids a year, maybe one a day if they were lucky. And others saw up to 9, 10, 11,000 a year. And one of the big things that I think you have to do when you're a PEC is if you're at a center that doesn't focus on pediatrics or doesn't see a lot of acuity, as kind of been noted earlier, you have to make the case for why should there be any focus on kids to people that are higher up. And one of our biggest angles in this was we actually added up all the pediatric visits that were out in the community. And we showed our hospital leaders that there was almost 70,000 kids being seen at these community hospitals. And that alone is the size of a big children's hospital. And that one little simple argument really gave us the momentum and the leverage to go to the children's hospital folks and say, we really need to help. And Meredith, you can go to the next slide. So some lessons, I think this little slide deck's not here to summarize everything that we've done, but I went back to kind of when we first started this 3 years ago. And I think what most people do if you're in a resource-rich area, like a children's hospital or maybe a hospital that's a level 1 trauma center that's got a lot of people, is you may presume that you know the things that other people need. And we absolutely did not go in with that approach. And I think that was huge in being an effective PEC. Really, the very first step in being a PEC is listening and not specifically coming in with an aim that we thought was the right one. I think for those of you who are working in your emergency department, that most of you have a really good sense of the pulse on where the comfort is for kids. But we really took the time to meet with frontline nursing staff, frontline techs at every single one of our community hospitals. And we asked them, what is it that makes it so hard to take care of kids? And we assumed it was going to be protocols, medications, pathways, referrals. And the number one most commonly thing that was addressed was organization. And we realized that for most folks, the pediatric code cart had never been open or literally had dust on it or had turned into what looked like a junk drawer in most of our houses where you put extra supplies in. And the simple idea of us promising to them that why don't we come in and standardize how all of your pediatric code carts are organized, including improving your reference binders for resuscitations, standardizing what the cart actually looks like when you open the drawers. Would that be impactful? And that little bit of taking the time to listen before deciding on what the aim was huge in being the first one of our quality improvement projects. As always, it's important once you kind of decide what's important to actually work on is to actually develop an aim that can be measured. And this is really important when you talk about reporting back and reporting up to the people who are supporting you. So we had this goal to within 12 months, we were going to ensure that every community ED had the same equipment organization. And you can go to the next slide, Meredith. So I think another thing that we thought about when we first joined was going into all of these hospitals and actually just giving them all the resources that they need, working with them and then leaving. And I think that as a PEC, I think ignores the fact that you can put together all the PDFs and QR codes and PowerPoint drives that you want. But if no one ever uses them or actually takes all your organization and uses them in their day-to-day practice, then implementation really is not going to work. And so the first thing we did once we kind of knew what we were working on was we looked at every single site and we said, what are the enablers? What are the things that are already built in place to actually help us succeed that work well in these rural sites or that work in medium-sized sites that we can leverage? One of the most common things that we heard when we would bring guests along, and this was a really great thing that we did, is every time I would go out to a community ED, I would bring along one friend from the children's hospital. I would bring cardiologists and neurologists, and we'd bring all sorts of specialists. And the number one most requested specialist to bring with me every time was child life. And especially the bedside nurses really found it comforting. And many of them said, we know that that's not what you're here for, but we would really like some more just information where we're organizing our supplies. It also has to do with child life. And those were the quick things that allowed us to be able to add some of that education to then sell our project, which is the reorganization of supplies. It was really important for us to identify who also thought that this was important. As you can imagine, bedside nurses, charge nurses, those who work day to day in the ED understood that that this was a problem. But almost nobody who worked outside of the ED really understood how much organization and how much standardization was important in the ED when it came to pediatric emergencies. And so we had to sell the value of this project to every single person in administration at these different hospitals based on their own titles. So for the risk and safety people, we brought up the articles that you've heard before about the increased risk of mortality in hospitals that were not pediatric ready. For the higher directors, I'm going to show you a slide where we actually showed them how long it took their nurses to find supplies if you actually had a code and you made it and you measured it with the stopwatch. For the educators, one of the biggest things that I've learned with educators is educators already do too much work. And so the real sell to educators was, let us offload some requirements you already have for pediatric training and let us make it this. Likewise, people who deal with patient complaints and satisfaction love the fact that when we were coming to reorganize the supplies, we also offered to paint some of the walls in the pediatric rooms and put up some stickers. And so these were all things that needed to be sold to those people to make them enablers of our project. You can go to the next slide, Meredith. As you can imagine, most of us can probably come up with a bigger list of barriers than we can enablers, and understand that change is hard, especially if you're talking about a place that maybe sees one kid a day and maybe hasn't seen a pediatric code in a couple years. I think that you have to accept the fact that you, as a person who is enthusiastic and taking a time on this afternoon to learn more, may be frustrated by those that you work with or work around or work for, that they don't have the same bandwidth or energy to focus on these things. And that's where I think coming up with the right aim is the most important part of any of these projects. Because if you have the right aim and you can get people to be enablers and allies to agree that your aim is important, then when you're measuring performance, we can actually prove whether or not we're actually making a difference. We're going to talk about the picture of what looks like a code cart and kind of what ended up happening as a modification for many sites where Braslo, where code carts may not be the right solution. I think the other allies that many of our PECs tend to forget about is that most of us are either intimidated or don't have the point of contact to use those people in the C-suite or at the highest level to be our allies. And I think what I've learned really more than anything else working with our community EDs, that it's the exact opposite, that many of these people want to help fix small problems. And if you can sell the fact that the fix is not a big chunk of money, but more about the organization or workflow, or I think for many of you, just the dedication of having a PEC who can provide feedback is huge. And so don't be afraid to go to those people who have the influence. You can go to the next. Oh, so the stopwatch is just a reminder. So that was kind of the big thing that we did when we went on every single one of our site visits is we asked every nurse, we asked the nurses that were working at the time to find us 3 supplies on the pediatric code cart, an ET tube, a laryngoscope blade, and if they had a McGill forceps. And it was educational for everyone. And you can go to the next one. So what change strategies do you employ? I think one of the biggest things that we learned when working with our PECs in the community, and us ourselves being PECs from the children's hospitals, is that we don't decide what gets to change first. Our sites really are the ones that tell you what are the things that need to get changed first in order for this to happen. In some cases, a lot of it was us dealing with their resource management team that actually was in charge of cleaning and organizing supplies. Now, for some of them, it was starting with pharmacy. For some of them, it was a blank slate, and they said, you can kind of come do whatever you want. I think that you have to listen so you understand what is making people reluctant to change and asking them specifically, what do they think needs to be changed first? Many of these people have pressure points either from trying to do this in the past, or it may be interfering with some way that they do things already. And coming up a list for us, I think a huge thing was developing a network. So when you go and work in one isolated environment. I think it's really common to think that your problems are your problems and no one else shares those problems. One of the unique things that we had in our area with 10 community hospitals is that I would go 100 miles west and 100 miles east, and those two community hospitals almost looked the same, but they didn't really have a way to communicate with each other about their same barriers. And simply developing that relationship and that network, all of you who are on this RPECs, is huge in actually leveraging change ideas, and kind of what works at one place that has a similar volume often will work at the other. You can go to the next one. So this is some of the things that happened as a side effect and as a direct impact of what we were trying to do. I think more than anything else is that once you start recruiting people, they want to know, have you made progress? And the best way to do that is to keep it simple. I mentioned our stopwatch test that we did at the beginning. The reason we did that is because I knew I could measure it again. It would be almost impossible for me to get a picture of what the cart looks like every week, or a paper report to ensure that all the supplies were there. But by simply telling people, hey, in 4 months, we're going to come back out, and I don't know who's going to be on staff, but we'll do the same test. It really made the site say, you know what, once we kind of keep this organized, we're going to make sure that this is maintained and a part of normal education. And people took a lot of pride in it. We displayed results. We compared hospitals that were of the same size. I think that, though, we talked a lot about being able to measure things, but I can't, and that's really the key to, I think, easily design projects, is having something you can measure. But I don't want to kind of undervalue the fact that subjective feedback is really important, especially when you're working in smaller hospitals where you may be the one person who's doing everything. So getting comments and getting feedback from your bedside nurses and from the people who provide care every day is hugely important. And I think if you're wondering, how do I measure that? The best way to measure those type of subjective feedback is to just simply ask the same questions all throughout your project. Sometimes we'll use survey scores, so rating from a scale of 1 to 5. How organized do you find the pediatric code cart? How hard is it for you to find airway supplies? How familiar are you with using a resuscitation binder? And then asking that question in the middle of your project, at the end of your project. That is a measurable target that you can use. Take to educators, take to nursing champions, and prove that a simple organization project can actually change how frontline providers feel. I think how you communicate your progress and your successes, as well as communicating your barriers, is key. This goes back to the very beginning slide, which is, who are your allies? Most of us who are on here, by definition, I would say that if you're on this call, you are an enthusiastic, proactive type person who likes to just fix problems and do the right thing. But many of us don't have the skill set to then brag about what worked. And most of us look at most projects and say, well, this didn't work. It is huge that all of you are doing this training as it is. And I think it's a great opportunity for you to try a project. And it does not matter, even if you know what the project is, if it's in smaller in scope than anything that you've heard, just simply organizing project and ideas is huge. And then bragging about what you're able to accomplish is great. When I send data back, I email everybody from the PECC at the local site all the way up to the CNO and the CMO. And I put the PECC's name in the email 10 times to make sure that everybody there knows that it was really the work of the frontline folks that made this happen. The pictures on the right are some of the interesting things that happened as a result of this project. The picture on the bottom left is actually something called the Braslo modular system. A Braslo modular system is from the same people that make the Braslo carts, but instead can actually get rolled out, and each individual item is self-sealed and packaged. At smaller sites, this was actually used and packed up in a go bag. Bigger sites liked the modular system because when you opened a drawer, it wasn't this messy arrangement of, like I said, like a junk drawer in a house, but it allowed individual equipment like airway equipment and supplies to be individually self-sealed and packaged. And most sites actually chose to have that Braslo system in their code carts. In this case, it was actually used in a go bag. The child life resources, and I'll kind of read some of these questions when I'm done here. I did not realize how much the child life people at a children's hospital really wanted to help out in the community. And so once I specifically reached out to the directors of child life at our local children's hospital, they offered to come, and in addition to organizing code cart supplies, they made an organizational cart, a little Rubbermaid cart here that actually had child life supplies that the nurses were trained on, that included ways to reduce pain, ways to make IVs less painful, ways to actually explain procedures to children. And even thanks to a philanthropist, actually donated iPads on a cart, which is frankly in the children's hospital, the most commonly used equipment during any procedure is that iPad on a stand. This was a huge win and a huge success. And there are a lot of interest at the children's hospitals to spread their wealth and knowledge. So cold calling and emailing these people is never a bad idea. We can help you with kind of contacting any children's hospitals that may or may not be in your area. Meredith, you can go to your next slide. I think that's it. I think sustainability, I will be completely honest, I find this to be the hardest part when you don't work regularly at a site where you're involved in improvement. Thankfully for everyone on this call, you are working and improving in the same location, in the same place. What the most important part is to take a moment and to really thank everyone who's at any moment engaged in your project. Even if I make it a note even to thank the person who was the least reluctant to change, just to let them know that by simply giving me feedback, it was very important. There are no small wins. And I think that that's also important, that simply just getting feedback on how pediatric care is often a success. But continuing the work needs to be part of your sustainability plan. So part of our sustainability plan for specifically the project we're talking about is we were able to partner with other specialists from the Children's Hospital. And we said, we have this program where we have gone out and reorganized supplies. Would you like to come out now and talk to them about the transportation of pediatric kids when you're transferring them in? And our transport team came out. That was followed by a visit from the NICU team, followed by a visit from the simulation team. In these ways, it let people know that you weren't just kind of there for just one project, and you were going to continue to kind of keep the help coming. That may be my last slide. And I think, hold on, I'm going to just try, before I just jump off, I'm going to try to read those questions that were popping up. I try to not be distracted. Yeah. Yes, I think that's a great suggestion, actually. In the United States, there are some actually standards for child life and what we call child kind hospitals, in addition to things in the community. And I'm happy to make an informal list for that. And then Michael, who made a comment, there's one other group that I did not, because you're out in the Northeast, that didn't advertise, that you're going to hear about probably during this, is the Impacts Traveling Simulation Group. It's led by Mark Auerbach out in Yale. That is a great example of children's hospitals going out to community EDs, doing on-site simulations, giving actual hospital scores on their performance, and coming up with an action plan together, and then going back out and making sure that those ones happen. So again, yeah, I think reaching out to everyone on here for resources, and happy to put together other lists too.
We're also going to have a child life specialist present at our, I think that's November
Yeah.
session on equipment, supplies, and medications, as well as Mark Auerbach is going to talk about the Impacts program later, I believe February, if I'm doing this off the top of my head. So you'll get to hear about those two kind of fabulous programs.
I'm just going to jump in and just thank everyone so much for bearing with us today as we struggle through some of our technical challenges. Hopefully not all is lost. I think these were some incredible presentations and really lots of great best practices to share. And I know that there will be so many more. I know that each of you has some wonderful efforts that you've already implemented that are underway, whether they be specific to pediatrics or not. And we really look forward to hearing more about those as we move through this whole process. The other piece is to say that we will be sharing as we go small snippets of quality improvement methodology and quality improvement science, with the hopes not to overwhelm you, but to really help you to integrate that into your everyday practice. And just know that this is really an iterative process, starting with this big picture of how we can improve pediatric emergency care. But really the first piece is just taking one small step. And your being here and being part of this is really a terrific first step. And our hope is that by the time we get to phase 2, many of you will feel ready to continue forward with the next step after that. So Meredith, I'll turn it back to you for housekeeping. Thanks, everyone.
Wonderful. Thank you, Kate. So just a few notes. The session evaluations for both the kickoff session as well as this session will be going out to you tomorrow. Those are set up as automatic reminders. So those reminders will go out every Friday until you complete it. That is to get your CE. So you must complete the evaluation if you want the CE credit for today. The focus area guide has gone out. And as I mentioned before, there is an online questionnaire component to that. Those emails will go regularly out on Mondays until that is completed, including the intake questionnaire. And really the intake questionnaire kind of helps us learn a little bit more about who you all are and what we can learn from you and what we can share with you to really help you improve pediatric readiness within your agency or your EDs. So as always, you can email me, PWDC@EMSC Improvement. We'd love your feedback. We'd love sharing of any resources that you might have for the group that I push out to everyone. As I mentioned in the chat earlier, we'll work on getting email links out, and I want to give some people some time first to opt out in case you don't want to have your email information shared, but then we can get some email chains going. And then the evaluation for today will go out. I can send it out this afternoon. I can increase that so it comes out so that you can get it filled out and get your credit. Slight difference. So CAPC for our pre-hospital practitioners, that'll go out all 8 credits at the very end of phase 1. So that will go to you guys. You'll get all 8 credits in for March, and then nursing is allowed to be on a rolling basis. So we will award those as we go along for our nursing CNE credit. But like I said, CAPC will come all at once in March. So, but do please fill out the evaluations as we go along. Yeah, the evaluation for the kickoff session, I didn't send it out yet. That'll go out this afternoon too, only because we tried to do a second version of it this morning for those that couldn't attend on the 2nd. So we'll hopefully get all the technology issues figured out and have everything go a lot smoother next time. So let me see the questions. CAPC, if we only attend live 2 or 3 sessions, you get partial CE. No, unfortunately, CAPC does not allow us to do partial CE. So we need you to at least try to attend all the live ones. Emergency Nurses Association for CNE will allow us to do partial CE, but CAPC unfortunately does not. So I'm sorry, it's a little bit of a sticky issue to have to make all 8, but Kimberly will have a newborn in December. So thank you for trying to join, Kimberly. Congratulations. And with that, I'll put my email in the chat one more time, PWDC@EMSC Improvement. And I just want to thank you all for your time today, for your patience with us while we had so many technical difficulties. But I really, really appreciate it. So thank you all.
Thank you, Meredith and Kate.
Thanks, Meredith.